topics and opinions expressed on the following show are solely those of the host and their guests, and not those of W4CS Radio, its employees, or affiliates. W4CS makes no recommendations or endorsements for radio show programs, services, or products mentioned on air or on our web. Any questions or comments should be directed to those show hosts. Thank you for listening to the Cancer Support Network on W4CS.com.
It's Arthi with Light Up Your Life, and it's Friday, and we're already entering into October, and it's already fall, and I hope that you are transitioning well to this season. I think I mentioned, I don't think it was on this show, but I was doing a filming for a small segment, and I shared that sometimes when we can feel that astrological pull when the seasons are changing. So a lot of people experienced kind of a difficult week overall. I think people are feeling off, and sometimes it helps to have some explanation. So that can be part of what's happened. It's just the astrological pull of our bodies and what can happen. So today's guest is Dr. BJ Miller, and I'm really excited about this conversation because, as you know, anytime that I get to talk about looking from death and dying to looking at life in that lens, I know that you have found the episodes we've done on that are really deeply meaningful, and hopefully they shed a lot of light for you and some of you who are in caregiving roles for someone who is chronically ill or, in those last moments, or we just really want to spread the message to know that there's hope and to know that there's a whole resource list of things that exist. And so I'm excited about today's conversation because Dr. BJ Miller is actually a really fundamental leading physician in the role of palliative care and hospice care. And he has a varied background, and now he's actually co-founded an organization called Mettle Health. And the co-founder, Sonia Dolan, and I have gone back and forth a lot about talking about how to really spread the message. They're doing awesome work on the West Coast, and how can we spread this message on this East Coast, where they've designed this organization to help really in all aspects of death and dying, and how to look at it in a constructive lens, to look at it in the modalities of mind, body, and spirit. And so I'm excited about this conversation, so passionate about this. You all know that, some of you know that I'm a death doula, know that I really have found a calling in working with end-of-life issues. And so today we'll also explore a book that Dr. Miller co-authored, A Beginner's Guide to the End. And this is a really, really, I feel like it's this great encyclopedia because it has everything. It also talks about what a death doula is. It talks about what it looks like in symptoms that one might be facing towards the end. I mean, just a really, really comprehensive guide I say to anyone who can really pick this book up, and we'll dissect this a little bit when we talk together. Dr. Miller is also medical advisor for the Partnership for Palliative Care, and he's also as part of the team that helps to make sure the Dream Foundation, which is an organization, a nonprofit that's been set up to help terminally ill families and caregivers. So he is part of that mission as well. So welcome, Dr. Miller.
Thank you, Arthi. You can call me BJ.
I was about to ask you what I can call you. So
yeah.
Yes. Well, your name is actually Bruce by trade, right?
Yeah. Well, BJ stands for Bruce Jr.
Oh, Bruce Jr. Okay.
Yeah.
Nice. So can you start off by just telling us how you got on this? Because you have a really phenomenal personal story. I think everyone has stories that need to be shared, but kind of your journey in getting here, because I don't think everyone knows how you got to this line of work. So we'd love to hear that perspective.
Yeah. I mean, you might have to shut me up. There's a lot to say about that, but I mean, the broad strokes are, it probably goes back to my childhood. I was raised the younger of two kids. My mother had polio and then post-polio syndrome. So I've been around disability my whole life, and was very close with my mom, and we didn't use the words caregiver, but that's much of what I did as a child. I was sort of attuned in that way. And then I went off to college and was doing my studies, and then got injured myself, electrical burns, screwing around on a commuter train in New Jersey, and ended up coming close to death, and then losing both legs below the knee and one of my arms below the elbow, my left arm below the elbow. So that was a big moment in my life, and that's what really catalyzed an interest in medicine. It did many things for me. It introduced me to death. It got me very interested in what human beings can, and our relationship with control, essentially. And those were the interests that I took into studying medicine. I was trying to figure out what I could do to work with this experience. And being a physician lit up as an interesting way to do that. So anyway, I went off to medical school. I was going to do rehab medicine, Arthi. That was what I thought. I thought I, as a disabled person, should go help folks who were recently disabled. But I fell out of love with that deep in my studies. It's a longer story, of course, but ended up was gonna quit medicine. Was going to drop out of medicine. I think a lot of people who go into medicine at some point there's a disillusionment. There's the idealism that you bring into this work, and then there's the realities of what it's like to practice it. But then I stumbled into palliative care one day. I did an elective on palliative care in my internship, and just fell in love with it immediately for all sorts of reasons. But that's a broad strokes what brought me to the doorstep of this field. We can talk about anything beyond there too, but yeah.
That's awesome. So, Dr. Matt, I have to talk to BJ.
Yeah.
BJ, so I think there needs to be some shedding of light on palliative care, because there's this big. So I just want you to start by defining it in your lens. What is defined by the AMA, the medical community, or anyone? But what's your definition of it, and what does it entail? Because I think there's a lot of myths around palliative care, and we could go into a lot with that subject.
Yes. Yeah, no, you're right on, Arthur. This is really important that everyone understands it, because the field is, like you say, it's very poorly understood. Even within the medical community, a lot of people don't quite get what palliative care is. So there are several, paragraph-long definitions of the field from the World Health Organization or the CMS, the Centers for Medicare and Medicaid. Everyone has their own basic definition that more or less overlaps, but it's long. It's like many sentences long because it's complicated. But the bottom line, I think, is that palliative care is the clinical subspecialty that sort of the interdisciplinary pursuit of quality of life. So, instead of diseases, palliative care treats suffering. Treats the subjective experience of illness. So we do a lot of work around symptom management, emotional support, social support. We do all the things that typically get left out of, or many of the things that typically get left out of the doctor's visit, the 15 minutes you have to address your whole life. So, sorry, long rambling answer, Arthi, but basically the bottom line is palliative care is the multidisciplinary pursuit of quality of life and the treatment of suffering. I think that's about as pithy as you can get it.
No, I'm glad you're defining it, because oftentimes, even from my own experience, when my mom was, when she was diagnosed with cancer in the hospital, and when it was time to come home, at the very end, they told me about palliative care, and I was like, wait, Wait, what?
Yeah.
So there's this need to understand what it is, and B, that
Mhm.
this awesome resource and what it can possibly do to help transition if you are moving. Not even people think it's that transition into hospice, but that's not even correct. So there's a
Right.
lot of myths. I mean, you and I could talk a lot about myths in medicine in general, but
Mhm.
this one myth that needs to be clarified, like it's so huge, I think.
It is. Yeah. It's a really big problem. I mean, so it gets confusing because hospice in a way came first in modern medicine. Palliative
Mhm.
care in a lot of ways is the oldest kind of medicine before we got seduced into thinking we could cure everything in the last 150 years of industrialized technologized medicine. But most of its history, medicine was at best going to help you feel a little bit better, and that's what palliative care does. So in some ways, it's ancient, but as a modern healthcare, it actually grew out of hospice. Hospice came from the UK in the 70s to the US and grew up in the 80s to become a Medicare benefit. And hospice is a beautiful thing. Nowadays about 45% of people who die on hospice in this country. So it's an important piece of the puzzle, but it's just a small piece of the puzzle. So in a way, hospice came first, and then in the 80s and 90s, clinicians, people who did this work realized, well, why do we wait till people are dying to give them this kind of loving support? Why wait to the deathbed? So palliative care in the 90s grew up around the hospice benefit to pull these principles farther upstream, get relevant earlier in life.
Mhm.
Because as you and I both know, a lot can be done in the final days and weeks of life to get ready for the end. But really, if you want to be really ready to die, it starts when you're living. It starts how you
Mhm.
live, how you treat other people, how you treat yourself, how you handle regrets as they come up, whether you reconcile relationships, whether you're trying to stay up to date and up to speed with your own life, so that if and when death comes, you don't have this pile of regrets sitting there.
Mhm.
So there's so many reasons for us to think about our mortality earlier in life. But to your point about palliative care, Arthur, you don't have to be you don't have to be terminally ill. Death is nowhere in the definition of palliative care. Some of my patients I've been seeing for 12, 13 years.
Mhm.
So
Mhm.
yeah, hospice, end of life care is a subset of palliative care, but palliative care is otherwise in no way concerted with death. It has nothing to say about the clock, how much time left to live, unlike hospice. Very different. Does
Yeah.
that make sense?
Yes, totally. And I really appreciate you, um, because this is a myth that they do go side by, because everything you
Mm.
see in the literature, palliative care and hospice, right? But today you are really helping to inform our community and myself to be reminded that it is an entity of its own that can start way before, or there, and to give the example of cancer, right? I'm sure, like you've seen with the cancer diagnosis, people who go into remission and who still need to have that aftercare. What does palliative
Mm-hmm.
care look like for them? Or
That's right. Yeah, a lot of my patients aren't. Not only are they not dying anytime soon, they're not even sick anymore.
Mhm.
They don't. They were cured of their illness or went into remission or whatever else, but that doesn't mean they're not suffering the impact of that illness. That doesn't mean their identity isn't struggling to catch up with their life. That doesn't mean they're not suffering.
Mhm.
So again, the operative word here is if you find yourself dealing with a serious illness or a family member dealing with serious illness, and you're struggling more than you think you need to, ask about palliative care. You get in palliative care and hospice work too. It's a doctor, nurse, social worker, chaplain. Inherently, this is a team sport because the
Mhm.
subject matter of suffering and meaning in life is too big for any one discipline. So no, you got this kind of loving support is waiting for you anytime you're suffering. The hard part is finding programs. They're not, if you're in San Francisco, for example, or some major city, you're very likely to have access to palliative care. Rural
Mhm.
areas, not so much, and also regional discrepancies. The Southeast, the northern Midwest oftentimes don't have as much hospice or much access to palliative care, which is why Sonia and I started Mettle Health, which we can talk about too at some point. Sorry, going on.
Yes, no, totally. So of course we talk about disparities. Disparities exist. One of the things when I was going through my death doula program was we were always concerned about racial inequities to access to services. So what are your findings when it comes to palliative care and hospice? Like, what do you all, what have you seen in all the different settings that you've been in? Because you've been in so many different clinical and so many settings with this field. What have you found when it comes to racial and socioeconomic disparities when it comes to the subject?
Well, there's the subject, and then there's this sort of interface with the healthcare system. And so, as of course, everybody suffers, everybody dies, no matter what race, what ethnicity, etc., what socioeconomic class, no matter how we might divide up the population. The things we have in common certainly include suffering and certainly include mortality. So as a subject, as a natural order, all are welcome. As a systems issue, as a man-made systems issue, well, we know healthcare has disparities all over it and amplifies accidentally, sometimes maybe not so accidentally, has created discrepancies in care that otherwise aren't natural. So if we're talking about the healthcare system, well, being part and parcel of the healthcare system, I see the same thing that you would in a hospital, which is uneven care, unequal access to care, different levels of health literacy. Doctors tend to speak in a ridiculous language, doctorese that no one really understands. Some people feel more comfortable than others asking questions. So there's a zillion ways where care gets unequally meted out within the healthcare system. And then the other thing is, especially within the world of hospice, there are cultural overlays. Well, not just hospice, palliative care too. There are cultural overlays. If your subject matter is suffering, that's an individual concept, but it's also a cultural one. How a people and their different rituals and different approaches to life, of course, are going to experience illness differently. So if you look at the roles of patients in hospice and palliative care, it's largely been Caucasian in nature. I mean, that's the sort of dominant culture within healthcare that's made it up. And that just you can see that play out in the systems issues. That's getting better. Hospice and palliative care as a field tends to be a very thoughtful field. And so it may be on the vanguard of healthcare trying to do something about it. There's a lot of work trying to get hospice and palliative care services to people, whoever you are, wherever you are. There's a sensitivity in the field to these issues. We've got a long way to go. But it's also true that some cultures, I think we need there's some more representation in the ranks of doing this work. Because we talk about mortality as though we all understand what we mean by that and we understand how we feel by that. But again, the cultural overlays are thick and relatively underexplored still in our field, which is a shame for access purposes, but it's also a shame because the subject matter is so much more interesting than the medical model lets it be, and that the sort of basic white Caucasian approach is one of zillions. So for so many reasons, this field, we would hope to see cultural, ethnic, spiritual overlays begin to be blossom and to be celebrated and explored, not pushed to the side.
Yeah, I wholeheartedly agree with you. I mean, you use the word holistic a lot in your book. And of course, when we talk about mental health, the holistic approach to what death and dying and what this whole aspect is of mind, body, and spirit. I mean, I don't think we can. I mean, there's no other, in my personal opinion, there's no other realm that you can really not incorporate all three of those when you look at this part of the timeline.
Yeah. Yeah, these are major questions: how we experience life, how we experience death. What do humans? We have such a funny lot in life that we all have to die. Fine, every living thing dies, but humans, we have this extra wrinkle that we have to know about it. We have this brains that we have this future-oriented brain that knows it's got to die and spends a fair amount of time defending itself against that. So we humans have extra layers and neuroses and fascinations around the subject. And to your point, Arthi, because everything must go, so everything is relevant. So yes, that means everything about being a human being. We are multitudes ourselves. We are spiritual beings. We are social beings. We are physical beings. We are you name it. You can chalk us up a zillion different ways. We're intellectual. We are aesthetic. We are many, many things, and all of these things have relevance because all of those things must go. So yes, that's one of my favorite things about the mega subject of mortality and the human condition and how we suffer and how we relate to life. Endlessly fascinating, and everything is relevant. So you can bring so many different avenues and so many different lenses to this work.
Totally. I mean, that's that's one of the reasons I love it so much. And I think you're right. It is the fact that you get into so many defining points of purposeful living, all of the things that are evaluation and yeah, totally. So can you, how did mental health come to be? Because was it that you were still practicing in the hospital setting? How did this vision come for you? And kind of what were you looking at when you started it?
So I had been teaching and practicing at UCSF, the University of California, San Francisco, for, 13 or 14 years. And loved that. And it was a wonderful time there. But that's squarely working within the healthcare system, and specifically a sort of a big regional academic medical system, even a stranger world in its own way than just in the old hospital. These sort of academic places become their own universes. And there was much to love about it. I mean, God, healthcare, we have a ton of problems with healthcare. But those tend to be the systems issues. The people toiling away within the healthcare system tend to be, oftentimes, are amazing people, or just incredible, brilliant, thoughtful, loving people. You go to a lot of trouble to become a doctor, a nurse, a social worker, a chaplain, a doula. I mean, it takes a lot of training, and it tends to attract some really beautiful people. The system is a meat grinder and can take a lot of that compassionate, loving kind of and scar you down and does weird things to people inside, whether you're a patient or a doctor. So I started to feel increasingly the systems issues coming to bear. When I was working in the hospital, there's a sort of demoralization that happens. There's just people would come into the hospital super sick, all sorts of things happening, and they'd get oftentimes really amazing care. And the palliative care team would be involved, and the family's getting heard, and everyone's getting loved and support, and processing big time emotions and getting clear on where they are in their life, and these big existential moments. And then there'd become this moment where it's time to discharge from the hospital and go home, and you just wheel folks to the door, and that the systems are so disjointed that all this beautiful work is just going to go, and that person will be back in the ER in a week or two or three, and you just see it over and over, and it's just absolutely demoralizing for everybody. So at some point, almost any clinician is going to have some moment where you have to say, am I going to try to work on the systems issue or step out of this system or something, because you're going to go nuts otherwise. So for years, I've been trying to kind of peck away at the system through education, through public engagement. And the last year or so, my partner Sonia and I just basically decided that we really wanted to step outside of the healthcare system as our next step, that working in the community outside the system with a line of sight into medicine, but not being beholden to its systems, made better sense for us. So we set up Mettle Health outside of the medical system. I'm not becoming people's doctors in mental health. We are teaching people how to use their doctors better. So we're sort of coaching and counseling. So that allows us to participate in the healthcare system, but not get caught up in it. And one more thing to say about that, Arthur, another reason why we did that was that people, because of the rise of telehealth, anyone with ostensibly anyone with a phone or a smartphone or a computer can reach out to us. You don't need a doctor referral. You don't need to live in the area of a palliative care program. So that was the other thing that Sonia and I want to do, is make good on this potential for telehealth to bring access to this kind of work.
Yeah. No, I think accessibility is key. And I think, again, like, you can service wherever you are, which is great. I mean, I know we talk a lot about, COVID has been an extremely challenging time, but I think when we look at what telehealth and telemedicine has been able to do, it's been quite remarkable. Some of the things that have been pulled out from this 2-year period.
Mm-hmm. Yeah.
Such as, when did you find your organization by? Was it 29?
Yeah, it was last year. We're about a year and a month or two in. It was sort of summer of 2020. So yeah, right in the heart of the pandemic. Yeah.
So you have counselors. I know. So can you tell us all of the kind of the multidisciplinary approach that you have decided to look at?
Yeah. So we have, among us, we have physicians such as myself. All of us are palliative care trained and have experience in this kind of work. That's where we're coming from. That's the lens. But some of us are doctors, some of us are nurses, some social workers, some chaplains, making good on the multidisciplinary piece of palliative care. And we also have a woman increasing, as we grow, we've got folks lined up to work with us, like from a nutritional angle, from an integrative medicine angle. So we really like to sort of, the subject's huge. We really want to match it with an array of people who can speak from various angles. So it's a direct to consumer. So you would just come to our website and schedule time pick a counselor that lights up for you and schedule time with us. We also have these little 20-minute freebies where you don't need to pay anything, just to test it out, ask someone some questions, get a sense if we can help you. We also have free monthly webinars just for educational purposes. We're going to be building out a larger platform, a communication platform underneath all this. So it's sort of a community building piece where we can share information. That's coming. So we got a lot of dreams for mental health that are coming. But right now it's nice and simple. Just go to the website, schedule either a free 20 minutes or a 1-hour session at a time with any of the counselors that light up for you. People come to us. Sometimes it's a caregiver. Actually, more than 60% of our clients are caregivers. Another reason why we set mental health up is the caregivers need support too, but they don't get that in the hospital or in the medical system per se. So a lot of people come to us with kind of learn the art of caregiving or sort of self-care, or a place to ask questions, or remote. People come to us for grief support, medical decision making, kind of talking through whether to treat this or that, how to treat this or that. Family dynamics. A lot of families get on the phone with us in our sessions and we can help talk things through if there are discrepancies in the family. If one brother wants to do X, Y, and Z, a sister wants to do X, Y, and Z, and how do we broker some compromise? Coaching folks on how to talk to their doctors, pointing folks to other resources like doulas, Arthi, home health aides, etc. So, yeah. That's the kind of work that's the kind of stuff we talk about. But anyone can come. Anyone's welcome. You don't have to overthink it.
I love, the more you get embedded in community organizations and the more that you look at what's offered, the more hopeful you become. I've become very hopeful in the last couple of weeks because there is such great work being done across the nation and the world, actually. But it is accessibility and great things in this country, but people often don't know, which you're right. The resources become an issue when people say, I didn't know about this program. I didn't know. So having something that's mental health focusing on palliative care, but then all of the arenas I think is great when somebody can say, I'm a caregiver. I just need, I need support. I want support. Where do I go?
Yeah, come to us. The caregiver support thing is huge. I mean, Arthur, I think it's 45 million Americans who are caring for someone at home and trying to hold down a job too. It's really difficult, and it's a huge number of people toiling in this way. So, and caregivers there's no training out there. There's no support for the caregiver.
Absolutely. And then, especially during COVID with respite care and some of the services that might have been an angle are also because of, again, they're just, the dynamics have shifted so much. And so I think caregivers to feel like somebody cares for them, to be held is so crucial. And I think for you all to make that a big part of your platform, I think is so awesome. I really think,
yeah. Thank you, Arthur. We love it too. I mean, I'm with you. Yes. I've seen a lot of in my time in the healthcare system. Ultimately, oftentimes the patient was okay, but sometimes the family who's really burning out, who are most distressed, etc. And they need, like we're saying, they need support too. So I love when we hear from caregivers here. We also have a caregiver webinar series as our monthly educational series for caregivers specifically. Yeah.
That's great because it's a whole subsect of this whole work is a whole different dimension. So tell us about your book that you co-authored. Was it written? Well, it was published in 2019, but how long have you because it's so multifaceted. I actually have a lot of books on the diets, but this one was really comprehensive because I really feel like you get all angles,
Yeah, that was the hope. I mean, it's not again, being in hospitals and clinics over years and watching how human beings, we suffer in all sorts of ways, but very often we suffer for a lack of just basic information, especially around end of life issues, because in our country, we don't like talking about death. We don't like thinking about it. So it's this sort of underdeveloped, mystery sitting in a closet somewhere. So a lot of people just don't even know what to think about it. So one of the impulses for the book was, let's just get some basic comprehensive level setting, lay the groundwork for the basics, all the things that go into navigating healthcare and bringing a life to a close, the logistics of care, the logistics of funeral support, getting funerals and memorials together, and shutting down digital accounts and all that stuff. Because so many people were left to figure this out for themselves, by Googling it. It's just crazy. And it's, in a very emotional time of life. And so to be drowning in administrative tasks online while you're trying to grieve or care for mom or care for yourself, it's nuts. So that main impulse of the book, like you say, is meant to be a comprehensive, here's the basics all laid out in one place, to be that kind of resource. And that was my friend and I, Shoshana Berger. She's comes from the design world, and we had the idea to write this book together, knowing that there was this dearth of information for people, and also knowing that the language that usually goes around death can be so off-putting, so opaque, so indirect. It can get confusing. To try to speak in plain language about this subject, it can feel a little dry perhaps, but we're just trying to kind of take some of the drama, tone it down a little bit, and let's just speak directly and practically. Family members will find something in it for themselves. Patients will find something in it for themselves. It's also about how to do advanced care planning and estate planning and all that stuff too. Well, yeah, it gets complicated dying in this country. So yeah, I'm just trying to make it a little bit easier.
Discussed, right?
Yeah.
I mean,
exactly.
you say it like left and right, like there have been a lot of people who did try to get their status of affairs in order in the last 2 years. That's for sure. Yeah. But we still, you hit it on the nail. The admin stuff does take away from that. Does take away from those last days or those last moments or those last weeks. And then, of course, you brought up the person who's grieving, who then get suffocated with the admin stuff that they don't get to actually work on their grief healing. And I'm sure you find this, BJ, in the work with grief, it can often be prolonged because that person didn't get to grieve the actual person. They're literally bogged down with this stuff.
Yeah. We don't do, we haven't honored grief in this country much. We, give you a couple weeks to be sad, and then you're supposed to be kind of back on the horse, or we'll call you depressed when it's just grief, or we just haven't made space for this. And then we've loaded it up with these mindless clerical tasks. And it's brutally difficult that way. This is supposed to be, it's gut wrenching, it's poignant, it's difficult, it's sad, it's many things, but it can also be beautiful and stunning in a way that it's a kind of a sacred moment in life. Death is, just as birth is. But we've cloaked it in all this sort of flat junk stuff. So it's a sad thing. But one hope would be that more conversations like ours, books like that, over time, maybe pulling more attention. Certainly a pandemic is pulling more attention to how we die, what it means to be ready to die, the limitations of our healthcare system. So maybe there's reason for optimism that there's some clarity coming and that we're all paying attention a little bit better, and maybe we'll get better at not gumming up all the beauty that happens around this subject too.
I agree. And also not to make it so age specific, right, BJ? Like, I think we call it the timeline of the 60s, 70s, and 80s. Well, these days people are living longer, but I often, I think if we start to live in the lens, if this was my last day on earth, how was it a good day that this is my last breath? Is this the last? All of these moments that you could look at, I find that maybe if we reflect and then we realize, okay, let me try to get my affairs in order for what would it look like for those left behind. I think we could do a lot in those small little moments, how we lead our daily life and how we could just take care of that. Like you call it is junk, but you have to do it.
Yeah. Well, there's the advance directive and doing your paper, getting your estate planning and your advance directive, stating your wishes, naming your healthcare proxy. These are all important things you can do to protect yourself down the road. But to your point too, Arthur, those are big macro level kind of structural things you can do, which I think are very important. But there's also this sort of smaller scale day-to-day, the way you live your life, the way you don't let regrets pile up, the way you tune into what's most important to you now, the way you try not to get caught up in the life that others want for you versus the one you want for yourself. There are all sorts of ways that you can bring the fact of mortality into daily life and use that. What if today's the last day on earth? Am I acting in accordance with myself? Am I loving where I can? Using that lens can really catalyze and sculpt a very beautiful life one day to the next. I think this is another reason why we wrote the book, and another reason I imagine you do your work too, is getting a beat on the paperwork and the clerical stuff and getting your head in the game, etc., can be helpful to mitigate suffering, to make it less hard. That's true. When death finally comes, if you've got all your affairs in order, it will be easy for you and your family. It will be easier for you and your family. That is true. But the other thing is, sort of a secret is, and that we know this from being in this world, what's also waiting for you if you turn your attention to mortality is more beauty, more kindness, more compassion, more love. So it's not just, we don't want you to think about this subject just to make life less crappy down the road. The point is, you can make your life more beautiful now by really paying attention to a bigger reality that includes death. So that's the exciting part. This is not just, a lot of people say, I bet you get it, who is a death doula? Oh, that must be so depressing or so sad. Well, yeah, but it's also amazing. It's also gorgeous, and it's also compelling as hell, etc.
And I feel like, when you work with seniors who are reflecting on their meaning of life, and not even ones that are terminally ill, when you work with that population, when you realize how they do evaluate and how they are looking at life, I always say, if you could just walk side by side with someone who's either on their close to they just will make you reflect on life in a whole new way. So I'm not saying you have to be in this work. I'm saying just have that, or I always say read Tuesdays with Morrie by Mitch Albom or something where you can have that reflective experience of walking alongside someone who is in that chapter so that you can navigate.
Yeah. And also, like you're saying, Arthur, most of us these days will die now of chronic illness. We will be given a diagnosis that we know someday will end our life. And we have, so whether it's old age or a diagnosis, sort of helping this become less abstract. Like, okay, we all know we die, sure, fine. But when you get a diagnosis or when you're in your 80s, or it becomes a little more real. And the questions become a little bit more relevant, not just sort of academic or interesting. So we're all on the spectrum, and it's also true that someday, a lot of us will have sudden deaths or a very short bout of illness like COVID, and it's not age specific. So we want to disabuse people this notion that, life is this thing that you ponder when you're an old person and retiree and rocking on your deck with the, iced tea. No. It's for now. It should start early in life. A, because it's fascinating and instructive, and B, because we really never really know what's coming tonight or tomorrow. It could be the last day. That is actually true.
It is true. And BJ, I think we look at legacy. We talk about legacy in terms of legacy planning for, oftentimes, of course, we do end of life care and in this work. But I often say, why aren't we focusing on living legacy? And the minute that we convert our language, the minute that we do that, then it does become, your life does become enriched, I feel. And, instead of kind of this aftermath of looking at legacy. Why are we not looking at living legacy?
Yeah. And I think it's an organizing question of like, just like, what if today's my last day? Another very organizing question is, what is the effect that I'd like to have on this world, in my life? What do I want to leave behind? What am I working towards? So, my contribution at my deathbed, did I leave the world a better place in any way, in some way, a small way, a big way? Those can be very, organizing questions for you to make decisions around and base your daily life around.
Totally.
Yeah, very useful and very beautiful. And I would say about legacy too, like, I don't want us to get caught up in, this sort of competitive legacy. Like, I want to have my name on buildings, and I want to have, amass some crazy huge fortune. Sure, if that's what you want to do, power to you.
Right.
But that's not but I don't think you or I are sinners saying that one legacy is better than another. It's just that humans will leave a legacy. You have an impact, good or bad. You can't not have an impact, small or big. We leave a residue behind. And it's just being thoughtful about the residue you want to leave behind. Is it an air of kindness? Did you make someone's day? Holding the door open, that's a beautiful legacy. It doesn't have to be a building. Yeah.
Yeah, you just back to what you took, simplicity, right? Keep trying to keep it simple.
Yeah.
So we're almost out of time, but what are some parting thoughts that you have, and what would you like to, if you could have one wish, what would your wish be?
Well, gosh, part of me wants to go on the heels of what we were talking about, the healthcare system, is like to start over and start from scratch with the American healthcare system and rebuild it from the ground up, knowing what we know now. That'd be amazing. I think it would make an incredible impact in this country and beyond. So part of me wants to go something like that. Part of me wants to say something like, just more to general for all of us, that I wish we could all find a way to craft a worldview, a sense of ourselves in the world that includes death, that includes suffering, that includes hard stuff, so that we're not at odds with our nature, so that we're not at odds with ourselves, so that we don't feel that death robs us of life, but that rather death is a part of life. It's just part of the deal. I think if we can merge those two worlds rather than seeing death versus life, man versus nature, I think a whole different experience of life is waiting for us if we do that. I suppose that's probably my bigger wish.
I love that you talked about it's not a versus. Like dichotomous pairs, we often look at good versus evil, but dichotomous pairs were never designed to be versus. It's just like yin and yang. It's in a coexistence.
Yeah.
So for you to bring up this coexistence,
Yeah.
so powerful. Do you have any book projects in the works?
Well, I'm working on a textbook chapter right now. It's due next week for the Handbook of Psychiatry and Palliative Medicine. I'm working on a chapter on aesthetics and the joys of meaninglessness. So we'll see how that comes out. Oh golly, yeah. Wish me luck.
I just the way that you write in here with your co-authorship, I just it's so great to read simple something that's so complex and just so simply written. It was such a pleasure to look through.
Thank you, Arti.
Well, thank you for your time, BJ.
It's a pleasure. Thanks so much for having me, Arti. All the best to you.
Thank you. Thanks everyone for tuning in and have a great week ahead.
Thank you, guys.
Thanks.